Bismillahirrahmanirrahim. Assalamu alaikum. I'm going to talk about hypos in Ramadan, who, when, and what to do. The journey about diabetes and Ramadan fasting started in 2001 with the publication of EpiDiar study, and since then the epidemiological data has been very useful for our learning. For people with diabetes, always the most important part is to be concerned about hypoglycemia and hyperglycemia, and for the physicians and the other stakeholders, this is of paramount importance. In 2010, 10 years after the EpiDiar study, we had another CREED study, but in the subset analysis of the CREED study, we focused again on the hypoglycemia during Ramadan. And as you can see, the incidence of hypoglycemia according to ADA risk status of very high, was 5.6% in Europe, 6.1% in Middle East, 8.7% in Asia, and 38% in North Africa. As we can see, there is a wide variability, which is highlighting that the cultural, religious, and the healthcare system affect a lot in terms of the risk of hypoglycemia. However, the incidence of hypoglycemia for this entire cohort was about 16.8% with the insulin treatment and 5.3% with the oral anti-diabetic medication. In terms of who and when, in the CREED study, we did a sub-analysis, and one important factor was that an episode of hypoglycemia before Ramadan was associated with a significantly high 7-fold increase in the odds ratio of hypoglycemia during Ramadan. And that's why we always ask the patient about history of hypoglycemia before Ramadan when considering the risk score for their fasting during Ramadan. Another study followed by that was DAR-MINA type 2 diabetes, an international prospective study this time. And again, because of the shortage of time, as you can see, the confirmed hypoglycemia increased significantly from 5% to about 10% and was dependent on the treatment regimen. And again, in many of the countries which participated, still insulin and sulfonylurea were useful. But compared to the CREED study, where it was 16.8 for the entire cohort, here it was 10.4. Learning further, we found that another hypoglycemia during Ramadan fasting, a transnational observational real-world study, in which there were about 1,759 patients, again, like CREED study, reported about 16.8%. Particularly affecting because it was the entire cohort, the type 1 diabetes or even type 2 diabetes, but those in particular who were insulin treated. So I think insulin treatment per se gives us a good assessment about the risk of hypoglycemia. In this study, we found that fasting was interrupted by 67% only of those who experience hypoglycemia. This is alarming. We always teach and educate our patients that once they experience hypoglycemia, whether it is confirmed or not, they should interrupt their fast. In the country-wise analysis, the rate of hypoglycemia was greatest in Egypt and lowest in Pakistan. Now we come to the recent new 2020 and 2022 global DAR surveys, first looking into the type 1 diabetes. And here you can see the top 5 countries contributing to the survey were Saudi Arabia, Egypt, Iraq, Pakistan, and UAE, although there were many other countries participating. And again, the frequency of hypoglycemia, the top 5 were Saudi Arabia, Egypt, UAE, Pakistan, and Algeria. As we see, it was a good survey. As we expect, male to female ratio was about the same, so they all participated. But important to note here that 18% had daytime hypoglycemia for more than 7 days during Ramadan. So when you are having so many episodes of hypoglycemia, what do? You should be careful. But 22% among the cohort reported to fast even after Ramadan. So that means spiritual benefits or the religious bindings make people so happy to continue with Ramadan, even after Ramadan, to fast. This is again alarming for me that 18.5% reported not to break the fast despite hypoglycemia. It is very difficult to interpret that if they were really hypoglycemic, how come they were able to continue their fast without interrupting it? And 6% were rushed to the ER or get admitted to the hospital for hypoglycemia. This is some of the data which is interesting to note. As you can see, type 1 diabetes population with 914, you can see here that as expected, A1C less than 7 was only in 16.6%. But in this type 1 population, which is always on multi-dose insulin therapy, about 34% had A1C above 9, about 23% with A1C 8 to 9, and about 25% with an A1C 7 to 8. And I'm wondering, how should we educate our HCPs as well as our patient that despite such high hypoglycemia, they were allowed to fast or they themselves chose to fast despite a very poor glycemic control in the setting of type 1 diabetes. The other thing which was a bit interesting for me, but surprising as well, that type 1 diabetes population, as you can see, 12 and 6, about 18% had an BMI above 30, which is surprising. But as I always say, now from the family history and genetic model, almost every person has got metabolic syndrome. So our type 1 population is originating from those who have got the genetic background of metabolic syndrome or insulin resistance. And as soon as they start treatment with insulin and their glycemic control improves, they become overweight and their BMI increases. So we have to be concerned about it. And that's why the new diabetes therapies may be finding a way into the type 1 management as well. Interesting to note, what was the action taken by these patients? These are type 1 patients after hypoglycemia. Very good to know that 48% reduced the medication dose, which should be done, but only 16% stopped fasting. They were able to manage on their own or with the guidance of their physician or diabetes clinic. 16% increased the frequency of monitoring. 15% continued fasting without any change, which is again alarming, and 6% booked appointment at the diabetic clinic. Important to note, we always emphasize that Ramadan specific education is important, very important. But even in this type 1 setting, from the whole cohort, it's reported that only 2.7% received a Ramadan specific education. For the same survey, 2020 and 2022 Global DAR survey, we have got the type 2 diabetes data. The further analysis is being done. Again, here we have got top 5 countries in the survey as Pakistan, Malaysia, Saudi Arabia, Iraq, and Algeria. The top 5 in the frequency of hypoglycemia, again, Saudi Arab, Egypt, UAE, Pakistan, and Algeria. It is because it is a frequency, so maybe it is related to the number of patients surveyed by these countries. Again, very much as expected, a good participation. The male to female ratio was 45 to 55. Here again, similar to the type 1, 13% had daytime hypoglycemia for more than 7 days. But again, learning, 40% reported not to break the fast despite hypoglycemia. So as explained earlier, maybe type 1 is a more concerned population or patient, but 40% here reported not to break the fast. So either it was not very severe hypoglycemia, or it was just symptoms of weakness and fatigue, because it was a survey, so we don't have the confirmed hypoglycemia data available. 27% reported to fast even after Ramadan. So again, it is highlighting that Ramadan fasting and fasting over the whole year for the Muslim population is important, and we should keep learning even outside the Ramadan the impact of these fasting, because Ramadan fasting is for 20 days, 30 days. So it is easier to adjust the dose. And sometimes I'm also worried when my patients say, if I have to fast on Thursday or Monday, what should I do? Because it takes time to settle on the new dose and come back. But to do it for a day in a week or 1 or 2 days is not easy. And we need to learn from the further data in terms of by looking at the prospective studies and other things. 11% of the population rushed to the emergency room or got admitted due to hypoglycemia. Again here, very shockingly surprising for me that, as you can see, 20%, 20%, and 30%. So about 76% of the population had an A1C from 7 to 17, and about 19 plus 36, as you can see, about 20 plus 25, 45% of the population had an A1C above 8, and still they chose to fast rather than being prepared for fasting with safe Ramadan experience. As expected, a large proportion of this type 2 population had a BMI significantly over 35, 10%, 30 to 35, 20%, and 41%, 25 to 29. This will be learning for us in terms of the future prevalence of diabetes in the population. What about action after hypoglycemia? As you can see, like type 1, 27% were able to reduce the medication dose. And important to know, why were they able to do it? Because maybe at some point they didn't receive the structured diabetes education for Ramadan fasting, but still over the course of their disease, they were told or they were aware that in terms of titration of the dose, whether it's injectable or oral therapy, only 16% stopped fasting. 16% again, much the same as type 1, increase the frequency of monitoring. Again, 12% continued fasting without any change. And I always say, if that is the so case, it usually, I suspect, is because hypoglycemia was one-off and most of the time they were hyperglycemic. Here, 12% of the patients booked appointment with their diabetes clinic. Very shockingly surprised again that only 3.5% received Ramadan specific diabetes education. If we compare the two, you can see it is much the same. Type 1 reduced the medication 48% because they are on insulin therapy and they have been guided how to titrate by 2 units minus or 4 units minus, whereas the type 2 population is usually not guided about their medication adjustment. They may be on once weekly injectable, they may be on daily dose therapy, they may be on the fixed dose therapy. Again, similar 16% and 16% who stop fasting, 16% increase the frequency of monitoring, 15% here in type 1 and 12% here who continued fasting without any change. And as you can see, which is very important, education, 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 as we always emphasize in all the diabetes and Ramadan forums, that it is crucial that the Ramadan focused education program is implemented on all aspects, even in the primary care family physician setting. It's not very difficult. It takes a very short time. And once you have taught your patient once, it may be useful in every year for the Ramadan experience. And here it has been shown that in terms of the intervention group, we did see that the hypoglycemia scores in those who had the intervention compared to the control group were significantly lower. So my final slide is to highlight what we have learned over the years in our epidemiological and other surveys and data, that hypoglycemia risk could be improved by our efforts in terms of properly educating, adjusting the dose before time, and telling the patients about when to interrupt their fast or when they get hypoglycemia and how to up or down titrate their dose. We know new diabetes therapies could change the risk significantly, and SCP's awareness is much better, but they are ready to guide, but we have to improve it. The patient awareness still needs to improve. As we saw, they were not breaking their fast, they were not adjusting their dose, they were not contacting their doctor, but still we don't have any strong evidence because we don't have the intervention data available. Ramadan focused education is important, but not available to all patients. And as highlighted repeatedly, and now with a very focused, repeated annual programs across the globe from the DAR platform, I must say and congratulate the team that DAR is an important and unique platform to work together on this important subject. Thank you very much. And we look forward to answer the questions during the panel session. Thank you.